So in this lecture series, we'll be learning about slipped capitofemoral epiphysis. So what is slipped capitofemoral epiphysis? Slipped capitofemoral epiphysis basically means it is actually a misnomer, okay? It is actually a misnomer. So why is slipped capitofemoral epiphysis a misnomer? Because whenever we talk about slipped capitofemoral epiphysis, we think that the epiphysis has been slipped, right? But actually the epiphysis is staying inside the acetabulum. It's just the neck which has been displaced, okay? So you can see in particularly if you look into this side, okay, over here, whenever you can see, I'll just show you along with the diagrams in this way because it will be easy for you. This is your growth plate, okay? This is a growth plate. So whenever there is a hairline type of fracture in your growth plate like this, the muscles which is attached to the greater trochanter area, it pulls this one, okay? It pulls this part. So this area, it stays inside the acetabulum, and this part, it goes upward, okay? And this is actually known as slipped capitofemoral epiphysis, number one. Number 2 point, you need to remember that whenever we talk about slipped capitofemoral epiphysis, what is the etiology of slipped capitofemoral epiphysis? Etiology. So I'll go through the slides, okay? But before going to the slides, it's important for you to understand. So understand the thing well clear. The slides are totally available. You can click screenshot or whatever you want to do, or you can make notes of it. Etiology is whenever there is increase in the growth hormone but decrease in the sex hormone, this will actually result in something which is known as Scfe. So what is the major thing that I'm saying here? Increase growth hormone, decrease sex hormone. So growth hormone, it is responsible for the growth of the growth plate, okay, like this. But its strength is brought about by the sex hormone, okay? If the strength is less, then there is high chances that the growth hormone will increase the size, but the strength will not increase, and there will be weakening of this growth plate, and that will be that will lead to a hairline fracture. And this hairline fracture is through the hypertrophic zone of the growth plate, okay, growth plate. Now what do we need to understand? What is the most important thing that we should understand is there is a hairline fracture in the hypertrophic zone of the growth plate. But what is actually the clinical presentation or clinical complaint that the patient will present is pain, okay? When will it be pain? The pain will be at the puberty. Whenever there will be, like a growth spurt, someone is trying to grow. In Nepali, it said walakke bornu, holatte bornu. Okay, it's basically a growth spurt, okay? Whenever that growth spurt comes to one point, it will lead to excess of the growth hormone, and there'll be severe pain in your leg, and of course there'll be antalgic gait, okay? There'll be painful gait. And more specifically, there's a particularly whenever we talk about these Scfe, it is always associated with some of the other factors. That will be number 1 is obesity, number 2 is your hyperthyroidism, or number 3 is your hypothyroidism, hyperparathyroidism, okay? So endocrinopathies, okay? These are all endocrinopathies in a nutshell. So this is usually seen in tall children, okay? And the most important hallmark whenever we talk about this slipped capitofemoral epiphysis is okay, so I'll write it down here. See, whenever we talk about slipped capitofemoral epiphysis, if it slips from its place, then what is the major thing that we should understand? Suppose over here it was staying over here. Now the epiphysis is still here, but the neck slips over there, okay? Particularly the patient will present with a gait, okay, that is known as Trendelenburg gait. And whenever you go through these particularly the diagram, okay, I'll show you with this one. See, okay, again you can see here. Suppose I draw a line from the lateral aspect of this one, right? And lateral aspect from this one. Can you feel the difference? So if you are not studying medicine also, I think you can see the difference. See, above this line, there's a small amount of head of the femur left over. Once again, see here. But above this line, there's no head of the femur. The head of the femur is right here. So Fracture is actually on this particular side. This side is the fracture. You can see this is the fracture side. Okay, and the epiphysis is inside the acetabulum, but this side it has gone outside, right? Let me show you. Everything I have just removed. You can see here beautifully, you can see here the epiphysis is still inside. This is the hairline fracture, and this has gone outside. Okay, so okay, now how will the patient present with? The patient will present with pain and all the features I told you. That decrease in the sex hormone means all the characteristic, like there might be gynecomastia, micropenis. This might also be the presenting complaint. The line drawn is actually known as a cleans line, and the sign that I was telling you is known as 301 sign. It's known as 301 sign. Okay, and whenever we talk about one of the most important factor, this is actually known as Shenton's line. See, whenever I draw a line from here, okay, in this way, it actually makes this particularly a curve. Okay, then this is known as Shenton's line, and this Shenton's line is basically disrupted in this particular picture. Okay, so this disruption of the Shenton's line is also a hallmark for slipped capitofemoral epiphysis. Now the next thing that we need to remember is the deformity. The deformity basically here is a coxa vara deformity. Coxa vara. So what is a coxa vara deformity? So normally if you say the shaft neck angle, so here is your shaft and here is your neck, right? So whenever you say a shaft neck angle, this must be particularly this has it has a limit. So if it decreases a lot, that means the shaft comes towards the midline. If the shaft comes towards the midline, then this is known as a coxa vara type of deformity. This is known as a coxa vara type of deformity, and this happens in the case of congenital coxa vara. This happens in the case of your developmental dysplasia of hip. This happens in the case of your Scfe. Okay, so these all are the features. All are the features, and the presenting complaint will be a Trendelenburg gait. Okay, so this was about Scfe. Okay, generalized concept of a Scfe. Now, any person with Scfe comes to the department of orthopedics. How are you going to treat the case of Scfe? So it depends whether it's a mild sleep, a moderate sleep, or it's a severe sleep. SLIP, okay, sleep, not SLEEP, sleep. Why am I saying about sleeps and all? Because as you know, we have been telling you this part, okay, this part, it is slipping from the actual place, right? So this part is not staying at its house, it's going somewhere else. So we want to keep this part at its house. Okay, so for this we need something to fix it, right? So exactly, here we are using certain pins. Okay, what are the different pins that we use? Are the Austin Moore pins, and we use cancellous cortical screws. Okay, cancellous cortical screws also. So let's go on to the slides and let's understand it. So the capitofemoral epiphysis is unique, right? It is one of the few epiphyses in the body that is inside the joint capsule. Slipped capitofemoral epiphysis, slippage of the overlying epiphysis of the proximal femur, posteriorly and inferiorly, weakness of the growth plate in relation to the metaphysis. I told you already that there's increase in the sex hormone. Okay, there is increase in the sex hormone, but there is actually a increase in the sex hormone, but decrease in the sex hormone and increase in the growth hormone will lead to actually a growth spurt, and it will actually lead to a fracture that lines along the hypertrophic layer. Okay, femoral neck and shaft is displaced upward and anteriorly related to the epiphysis and the acetabulum. Now it's more common to males. Contrarily, whenever we talk about developmental dysplasia of hip, it's more common to females. Okay, it's more common to frank breech females, etc. So bilateral slippage is common, occurs after 12 to 18 months of first, okay, and left is more affected than right. Boys are much more affected than girls. Okay. Next, obesity is the most important factor. Endocrinal disorder, hypoparathyroidism, hypogonadism, and growth hormone excess and sex hormone deficiency. Okay, this is actually the thing. Next, this is the pathology. I don't want to go to much more details because I've already talked about the details. Okay, and if you can remember the names, it's known as Loder's classification. Okay, you don't need to remember all this thing. Loder's classification. And I already talked about 301 sign as well as Clean's line. Okay, And mild sleep, moderate sleep, and severe sleep. Whenever we talk about mild, moderate sleep, severe sleep, okay, mild, moderate, and severe, okay, mild, moderate, and severe sleep. Severe sleep means this is all seen in the lateral view, okay, lateral view. Whenever we talk about anterior posterior view, okay, anterior posterior view, in anterior posterior view, it is on regards to the width of epiphysis. Oh, I'll take a fresh page and I'll help you out, okay, in this one. See. So if you say in anterior mild sleep, okay, mild sleep, SLIP, in anterior posterior view, it is less than 1/3 of epiphysis, of width of epiphysis. Moderate sleep means 1/3 to 2/3 of the width of epiphysis. More than 2/3 means it is on the AP view. Okay, more than 2/3 sleep on the AP view. And if you talk about the lateral view, it is actually less than 20 degrees of tilt, and then it is 20 to 40 degrees of tilt, and then it is more than 40 degrees of tilt. Okay, this is actually the classification. Or you can also write less than 30 degrees, 30 to 50 degrees, and more than 50 degrees. Okay, here it's 20 degrees, 20 to 40, and more than 40. It's taken in this way, and here it's taken like less than 30, 30 to 50, and more than 50. Okay, so mild sleep is less than 1/3, moderate is 1/3 to 2/3, and severe is more than 2/3. Okay, now this is the frog leg view, AP view. AP view, I already told you. AP view, what are we going to look? We are going to look at the width of epiphysis. Okay, width of epiphysis. Okay, AP view, we look into the, this was the cleans line. Okay, so I already told you about the diagnosis. Diagnosis is a radiological diagnosis. You can make it. You can make diagnosis looking at the history, right? And talking about the treatment, I already told you, if it's a mild slip, okay, if it's a mild slip, then you can just go for reduction and fixation with Austin Moore's pin under fluorescence control. Okay, so we just use the Austin Moore's pin under fluorescence control. If it's a major slip, let's say first of all moderate and then severe. Okay, so moderate slip. If it's a moderate slip, you can go for open reduction, internal fixation with cortical cancellous screw. Open the fracture and look for the obvious deformity. Now if there is deformity, and if you have to go for osteotomy, you go for osteotomy, or you can go for epiphysiodesis. What is epiphysiodesis? Epiphysiodesis means you connect the epiphysis with the with actually the neck of the femur. Okay, so this this is actually slides for PG people. You don't need to much more. So this is here, this is a cortical cancellous screw. This is actually fitted in this one, right? Or if in case you have to go for open reduction, you can go for open reduction with osteotomies. Okay, and corrective osteotomies can be done, and open reduction. And if you go for a corrective osteotomy in the case of severe Scfe, this is known as Dunn's method. Okay, Dunn's method. So in a nutshell, let's revise everything in a nutshell. I'll take this slides itself, and I'd like to revise from the beginning. Scfe means slipped capitofemoral epiphysis. This is a misnomer. Here the neck goes superolaterally. The epiphysis, it remains inside the growth plate. Number one. Number two, you need to remember this is a Salter-Harris type 1 classification, and here it is seen bilaterally in the 40% of the cases. Okay, usually the left hip is affected. Left hip. Okay, left hip. What is the presenting complaint? It's pain during the puberty, along with hypothyroidism, hypogonadism, increase in the growth hormone. It is seen more in male children, tall children, and obese children. Certain syndromes like Turner syndrome and Klinefelter syndrome can also be associated. Next, there'll be hip pain at the time of puberty. Boys are much more common than girls affected. Girls are commonly affected in the case of DDH. Okay, and I told you about two. One is Klein line, KLEIN epistrophes. Okay, please check the spellings. Okay, KLEIN epistrophes, Klein line, and other one is 3-to-1 sign. Next is Shenton's line is disrupted, and you can also write about Trendelenburg gait. Coxa varo will be there. Trendelenburg gait. Mild, moderate, severe slip. If there is a mild slip, less than 1/3, 1/3 to 2/3, and more than 2/3. Okay, and here less than 20 degrees, 20 to 40, and more than 40. This is on the lateral view. Okay. Treatment you will go for Austrian mode spinning here, your open reduction with cortical cancer screw, or you can also use a osteotomy. Here you have to go for corrective osteotomies. Okay, this completes our lecture on Scfe. Thank you.